and Gabriella Tikellis will be giving us a presentation around the impact of COVID on people with ILD. And she's from Monash University and works with Anne. And Anne Holland is going to introduce Gabriella in more detail and perhaps just give us a bit more of an overview about what her group's been up to. Over to you, Anne.
Thanks very much, Paul. So it's a great pleasure today to introduce Dr Gabriella Tikellis, who's a research fellow with us, as Paul said, at Monash University. We were very fortunate a few years back to tempt Gabriella to come and work in pulmonary fibrosis with us. She brought a great deal of experience from other medical conditions, and we're very happy that she's been able to apply that to the work of the CRE. And Gabriella particularly works in the translation, education and support arm of the CRE. So the aims of that are to ensure that we deliver best practice care to people with pulmonary fibrosis across Australia, wherever they may be, and that we have appropriate educational and support resources in place for patients and for caregivers. So Gabriella's worked across both of those arms. One of the things that she led in recent years was our research priority setting exercise for people with pulmonary fibrosis, so that included several hundred patients and caregivers, as well as health professionals and researchers. And that was the world's first list of research priorities for people with pulmonary fibrosis, coming from a consumer perspective. So that's been really useful in terms of shaping our research for the future. And more recently, Gabriella's published on the implementation of our position statements on IPF care across Australia. And again, that's been incredibly useful to look at what we're doing well, but also where the gaps might be. And really useful in highlighting things like gaps in access to care for people who are located in regional areas, and potential for things like telehealth applications to bridge that gap. So today what Gabriella's going to present to you is some collaborative work that's being done in the CRE, and she's been leading this process. It arose out of our conversations in the pandemic about what was happening to patient care and how that was being rapidly transformed, and how that impacted on patients and perspectives as health professionals about how that was delivered. And I think there's going to be lots of things that we can learn from that in terms of delivering best practice care for the future. So over to you, Gabriella.
Hi everyone, and thanks very much, Anne, for that introduction. So I'm just going to share my screen. Hopefully that will all work as planned.
Sorry, can I just ask anyone
Yes.
who's not speaking to put their microphones on mute? Otherwise we get a bit of background noise interrupting. Sorry, Gabriella.
That's right, no problem.
Okay, over to you.
Okay, so can you see my notes?
We can see, yes, where the notes are, okay, so it's not in presenter view.
Is that better?
Yeah. Yes, okay. That's better.
Thank you. All right, well, first of all, I'd like to thank Paul, Tam and the Create team for the invitation to present today, and also the CRE for the opportunity, and in particular, and for the opportunity to undertake this work. So as mentioned today, I'm going to be talking about the findings from part of a larger study that looked at the impact of the COVID-19 pandemic on the healthcare experiences of people with an interstitial lung disease. So the pandemic has seen a rapid transformation of society and health services that has resulted in a sudden change in access to healthcare. For people with ILD, these changes have included face-to-face services ceasing or being curtailed and often replaced by telehealth formats. People with ILD have had regular appointments that have been cancelled or rescheduled. And also there's been a delay or rescheduling of fundamental and routine ILD-related assessments. In addition, supportive care services such as pulmonary rehabilitation programs have either ceased or been delivered via telehealth. In terms of health professionals, there's been rapid utilisation of telehealth options that have often been associated with challenging technical issues and infrastructure requirements. Diagnosis and monitoring of patients were often undertaken without key tests or assessments, and health professionals have often been confronted with greater administrative burdens that were associated with the ongoing rescheduling of appointments as COVID restrictions were modified, and also shortages in staffing as people were redeployed to COVID-related roles. So alongside the changes to health services, there were heightened levels of stress and anxiety in daily life that significantly had significant psychological impact for many. For people with ILD, the self-isolation, reduced social interaction and ability to remain physically active has resulted in higher levels of stress and anxiety. And this has been compounded by the fear of not only contracting the virus, but of the possible consequences. For health professionals, the psychological impact has often been a more personal one that was associated with being able to continually provide best care for patients in a changing and challenging environment. So key components of the public health response to COVID-19 have focused on identifying groups at increased risk of exposure to the virus. Emerging data supports anecdotal evidence that people with ILD have an increased risk of both in-hospital and out-of-hospital mortality from COVID-19 compared to adults without ILD. And this is even after controlling for key variables and factors such as age, sex, and comorbidities. In a multi-centred retrospective case control study of 46 patients diagnosed with ILD from 6 medical centres in Boston, Esposito and al. Reported that the odds of death in people with an ILD and COVID were over 4 times greater than those without ILD, even after adjusting for multiple factors. In an international multi-centre audit of patients with and without ILD admitted to hospital with COVID, Drake and al. Reported that patients with an ILD hospitalised with COVID had a 60% increased risk of dying compared to patients with no ILD. And this was after adjusting for a number of factors as well. So predictors of non-survival that are identified from this study included advancing age, male gender, poor lung function, and obesity. So as a group of people anecdotally seen as being more vulnerable to adverse outcomes resulting from the pandemic, the extent of the impact on the physical and psychological well-being of people with ILD remains unclear. And to address this issue, several cross-sectional studies have been conducted. So in May 2020, the LFA conducted an ILD COVID-19 impact survey. Of 62 respondents, 95% felt that they were well informed about the actions needed to take part, to protect themselves or their families. When asked about issues that were of most concern to them at the time, 29% reported changes to their own health and well-being that included exacerbations and pre-existing conditions of being of great concern. 19% reported concern over being diagnosed with the coronavirus, 17% ongoing isolation, and 13% on having timely access to health supports or services. So since the introduction of social distancing measures, 23% of respondents indicated that they felt anxious and concerned for their health. 18% were exercising less, and 12% felt that they had become fearful, anxious, or depressed. In addition, 5% felt unwell or indicated that they were feeling that their lung condition had worsened, and 24% spent less time with their friends. So the survey findings indicated that even as early as May 2020, the COVID-19 was significantly impacting on the psychological and physical health of people with ILD. Restrictions implemented to protect those at risk led to anxiety and the feeling of isolation. So the Irish Lung Fibrosis Association conducted a survey between April and May in 2020, gathering the perspectives of patients with ILD and their carers, and they focused on the impact of the virus on daily life, healthcare needs, and mental well-being. So there were 111 ILD respondents, of which 80% had a diagnosis of IPF and 59 carers. 32% of ILD patients and 42% of carers reported being extremely worried during this time, with the most common worry for patients being the fact that they may contract the virus. Carers, however, worried about the health of both their family and friends. From qualitative interviews that involved 7 patients and 7 carers, cancellations or delays in appointments were identified as the main source of anxiety for these patients. Telephone consults, while generally well accepted, were not considered optimal for ease of communication, and there was a reluctance by patients to attend hospital if they needed to. So findings from this survey indicated similarly that markers of emotional distress and negative impacts on daily life were more common in carers and patients and higher than the general public, and that key concerns for patients was the ability to safely access hospital services. In April 2020, the Asthma UK and British Lung Foundation partnership conducted a survey of respiratory patients across the UK. There were over 1,900 who completed the service, of which 83% had been diagnosed with asthma and 2% had ILD. Of all respondents, there were approximately 80% who were female. So when they looked at the impacts on healthcare provisions, 45% of respondents reported disruptions in healthcare provision, and this included cancellations of GP and hospital appointments. 31% reported appointments with GPs were being conducted remotely, and 81% indicated they were able to keep active or do exercise at home, with housework and walking being the most common type of activities. 26% of respondents indicated that GPs were their main sources of support and information during this time, and 73% used the television as a source of information about COVID-19. Looking at the social and psychological impacts, 34% of men and 24% of women felt they were coping well. However, there were high levels of anxiety that were reported, and the levels were slightly higher in women than men. So the most commonly reported concerns related to their lung condition and concern about their family, and 66% felt isolated from others. So from this study, the COVID-19 was having a significant impact, generating high levels of anxiety and concerns about potential impacts on respondents and their families. The impact was compounded by social isolation and loneliness, and many aspects of care being cancelled or deferred. So the overall aim of our study was to examine the impact of the COVID-19 pandemic on people living with ILD and the health professionals that were responsible for their care. So this has involved describing the experiences of people living with the condition in relation to managing their disease and well-being, as well as the health professionals in providing clinical care and management for their patients. We'll also aim to examine the impact of the pandemic on key metrics of clinical care and the overall well-being of people with ILD. So one aspect of the study is focused on investigating the impact of the curtailment of ILD clinics and respiratory services on people with ILD. The areas of focus have included changes to access to health professionals, the availability of fundamental routine ILD assessments, the impact on access to supportive care services and clinical trials, as well as the impact that pandemic restrictions and isolation were having on people's ability to manage their disease and overall well-being. So the study also examined the impact of the pandemic from the perspective of health professionals. This focused on the impact that the disruptions to ILD clinics and respiratory services were having on the management of people with ILD. And this included challenges associated with being able to provide patients with routine assessments, the impact on consultation, diagnosis and treatment, access and referrals to supportive care services, administrative burden, and on a more personal level, the impact on their own health and well-being. So the study involves 4 ILD clinics located at the Alfred, Austin, Royal Prince Alfred and Fiona Stanley hospitals. And so health professionals were recruited from each of the respective sites and invited to participate in 2 over-the-phone semi-structured interviews that were held 6 months apart. These interviews are aimed to provide an insight into the health professionals' experiences of providing care for their patients during 2020. Patients with ILD were also recruited from each respective clinic over an 8-week period that spanned from March to August 2021. Eligibility was based on a predefined set of criteria. The study requirements for people with ILD included 2 over-the-phone semi-structured interviews held 6 months apart, as well as the completion of 3 questionnaires. So one of the questionnaires was a study-specific COVID-related questionnaire that was designed for this study and this was focused on understanding the healthcare experiences of people with an interstitial lung disease. And for those that completed the questionnaires, we extracted clinical data from the medical records that allowed us to categorise the respondents. So our current status is that we have completed recruitment across all 4 sites. We had a total of 153 eligible patients, of which 65% completed the COVID-specific questionnaire and 62% have completed the first interview. 50% completed both the questionnaire and the first interview, and there were 26% of eligible patients who did not take part due to lack of interest, being unwell or unable to contact. And we're now currently in the process of completing the second and final follow-up interview. So I'm going to now present an overview of the results from the 99 participants who completed the COVID-specific questionnaire. And as I mentioned previously, the questionnaire focused on understanding the healthcare experiences of people with an interstitial lung disease. The questionnaire allowed respondents to provide open text comments, and this allowed us to be able to undertake thematic analysis of those comments. So looking at the characteristics of respondents, and this is data from just 3 of the 4 sites, we're still waiting for the data from the final site to be transferred. So on average, our respondents were aged around 67 years of age, with 45% being male. We had about a third of respondents who had been diagnosed with IPF and about 30% who had connective tissue disease related ILD. However, we did have representation for a number of other ILD types as well. We had 61% who were former smokers and 79% who were currently on ILD medications, and these were primarily the antifibrotics. 11% of respondents indicated that they were currently on supplemental oxygen, and 25% had participated in pulmonary rehab in the last 12 months. When we looked at BMI status, on average, respondents were in the overweight category, and the mean distance travelled walked as part of a 6-minute walk and test was 482 metres. The percentage predicted FVC was 73% and the percentage predicted DLCO was 54%. However, we did have quite a range across those measures. In terms of the main comorbidities, 41% had autoimmune rheumatological disease and 38% had some type of heart disease. Other common comorbidities included diabetes and non-hematological cancers. So we asked respondents to rate their overall health during 2020 compared to the months prior on a 5-point Likert scale. And we found that 55% reported or indicated that their overall health during 2020 was about the same to months prior. However, we had 38% who reported their overall health has been somewhat worse. So when we looked at the comments provided, we found that those whose overall health was about the same or a little better attributed this to the fact that they had had no colds or had not been unwell during 2020. And this was primarily due to the fact that they were socialising less and interacting less with others. In terms of those that indicated a slightly worsening of overall health, the main reasons for this was attributed to the fact that they had a decrease in the amount of exercise or physical activity that they were able to do. There was a deterioration in their symptoms, and this was often or associated with their lung condition. So they felt they had an increase in breathlessness or cough. And many attributed this also to the fact that they were not able to exercise as much. There was also a psychological impact, the stress of depression and anxiety, and in particular, the increased stress was associated with the risk or threat of COVID and the possibility of dying if caught the virus, and of course, the ongoing isolation. We also asked participants how likely they were to seek medical assistance during the pandemic compared to previously. And we found that the vast majority indicated that their likelihood of seeking assistance was about the same during the pandemic as previously. So when we looked at the responses, we found that those that were less likely to seek medical assistance did so because they avoided contact or interaction with clinics or GPs or hospitals due to their concerns regarding the risk of contracting the virus. Many indicated that they were complying with the restrictions of the time and therefore were unable to travel to city appointments. And also many were aware of the stress and pressures that health professionals were under and didn't want to add to this. For those that were more likely to seek medical assistance during this time, it was mainly related to the fact that their health conditions or symptoms were deteriorating and required more frequent monitoring. We asked respondents also to rate their access to health professionals during the pandemic in 2020. And we found that 56% rated their access as being good, while 38% rated it as somewhere between fair to poor. So again, when we looked at comments that were provided, those that had rated access as being good felt that their appointments were well managed, that telehealth worked well for them, especially for just for scripts and referrals, and they felt that health professionals were making time for them and were available when needed. Conversely, for those that felt access wasn't as good, they indicated that for them, appointments were harder to get. They often had missed scans or lung function tests, and this created a feeling of unease as they couldn't monitor their symptoms and their condition. For many, telehealth was not ideal, especially when having breathing difficulties, and they found it less effective and less reassuring, and for some, unable to provide a diagnosis at the time. We asked respondents to rate their satisfaction with care during the pandemic, and 54% indicated that they were very satisfied with the care that had been provided to them by their health professionals. 42% indicated they were satisfied or somewhat satisfied. And when we looked at the reasoning for this, those that were very satisfied felt that they had received good care when needed and they were well looked after, and they had had minimal disruption to their care. For those that were just generally satisfied, there were some that felt that those with COVID were provided with more care than those with existing illnesses. For them, the telehealth was a disappointing experience, and they were not confident that they would get treatment if needed. For those that indicated they were not satisfied at all with their care, this was mainly due to the delay in assessment of lung conditions and delay in particular being putting on the waiting list for lung transplant, which was described as one respondent as soul destroying. In addition, some felt that there were lack of services available for them and that they were told they would have to look after themselves. So we asked respondents also to indicate what contact they had with health professionals, and 91% indicated they had contact with a respiratory physician and 68% with their GP. In addition, 32% indicated contact with other health professionals that included rheumatologists, immunologists, and a psychologist, amongst others. So we then looked at the format of the contact, and we found that for respiratory physicians and GPs, by far the most common form of contact was over the telephone, whereas for nurses and physios, this was mainly face-to-face consultations. So overall, the majority of telehealth visits were conducted by telephone, and there appeared to be little uptake of video conferencing. We also then looked at the reasons for contacting health professionals. And across the board, the main reasons were they were part of the regular follow-up or regular appointment, and a symptom deterioration requiring them to seek further assistance. For GPs, there are also issues relating around infections and vaccinations for their patients. We then asked participants if there were any regular health services that were not accessible to them during this time, and 30% indicated that that was the case for them. So the services that were not accessible were the pulmonary rehabilitation programs, and this was because many of them had stopped running, lung function tests and lung biopsies given services had closed, and face-to-face programs with specialists or GPs were not available, and telehealth was the only option, and this was not acceptable to all. We then asked participants whether they took part in any exercise or physical activity during the pandemic. And we found that 75% indicated that they had. Of those that, of the 75%, we found that the most common type of activity was walking, along with other types of exercise at home, as well as other sort of leisurely activities such as golf and fishing. We asked the respondents to rate the amount of physical activity that they were doing during compared to before the pandemic, and 44% indicated that they were doing a lot less, and a similar proportion reported doing about the same or a little less physical activity during this time. We also looked at the assessment and tests that respondents have been able to have performed during 2020. And we found that 58% had actually had some type of imaging, 85% had a blood test for various reasons, 67% had had a lung function test, 18% had participated in clinical trials, and 41% of respondents had had a COVID test. However, there were no positive outcomes. We also looked at medications and infections and hospitalizations during this time. And we had 75% of respondents who were currently taking medications for their lung health, of which 27% reported issues associated with having access to these medications. And the issues were primarily around the supply at their local pharmacy or script related. So the consequences of this was that for some, there was a delay in them starting the treatment, and for others, they actually had to stop taking the medications. And this led to feelings of frustrations and anxiety, as for many of them, it required more trips outside home and therefore greater risk of infection. So we asked respondents about whether they received information from their health professional regarding COVID and the pandemic. And 54% indicated that they received some information from a health professional. GPs and respiratory physicians were by far the most common health professionals that provided information. However, nurses and media interviews with other health professionals were also frequently listed. I apologise. So the information that was received by respondents included what to do during this time, and the health professionals stressed the use of masks, social distancing and hand hygiene, as well as the need to self-isolate due to the additional risk that was associated with having a lung condition, and also the importance of vaccinations. So in terms of the usefulness of the information they received, overall respondents felt that the information was either very helpful or somewhat helpful. And 16% felt that they would have liked more information. And this information included things such as related to COVID vaccines, for example, which one should they be getting? the ability to be able to recognise symptoms of COVID over their current lung condition, the risk of COVID on their lung condition, and how unwell I could get if I contracted the COVID. So in summary, the findings from our questionnaire indicated or suggest that overall people living with ILD were generally satisfied with their care during the pandemic in 2020. Reduced access to health professionals was at times challenging for those particularly who were experiencing a deterioration in symptoms or health, and that telehealth has been generally well received, however, did not always meet the needs of people with ILD when they were unwell. So therefore, the optimal telehealth model for patients with ILD during a pandemic and beyond remains to be established. And so our findings indicate that the impact of the pandemic is significant for people with an ILD. The decrease in physical activities, issues with access to care, the ongoing social isolation and heightened levels of anxiety and fear regarding the consequences of contracting the virus being key areas of concern. And just finally, I'd like to acknowledge and thank all of those involved in this study, in particular Anne and Tam, and also all the participants who completed the questionnaires. Thank you.
Thanks very much, Gabriella. If you could perhaps stop sharing your screen. Yes. Very interesting. I guess one thought that occurred to me was the heterogeneous community level of COVID during the time of this study, both time-wise and between, for example, Fiona Stanley in Western Australia and the Victoria, New South Wales experience, which had been very different. I mean, during the course of your study, I just can't recall the incidence of COVID over that specific time in 2020. I mean, what do you think the impact would have been at different time points? And I guess we're now in a situation where we've got vastly more COVID going on, but at the same time, we've got much less restrictions.
Yeah. I
wonder if you could comment on the likely impact of that.
Sure. And so that was actually something that was at the forefront when I was doing the analysis of the questionnaire, because, and perhaps, you know, the Austin and Alfred was similar, but perhaps RPA not as severe in terms of when the recruitment was taking place. But also, you know, Fiona Stanley, the recruitment was, you know, months later to the other 3 sites. And so it's interesting that in looking at the findings, you know, there were certain areas such as, you know, the ability to continue physical activity and, you know, having a little bit more face-to-face consultations was slightly higher in Fiona Stanley, but not a standalone sort of significant where you think, oh, this is like a totally separate situation. And often at times, the proportions, perhaps, you know, that consulted, you know, their respiratory physicians was quite similar to one of the other 3 sites. So there's no sort of standalone distinction between what's happening in Fiona Stanley and the other 3 sites across, you know, the time points that we looked at. And I think it really, the impact is really an individual one. And even in Fiona Stanley, there was a lot of reporting of isolation, and a lot of it was self-imposed isolation, not necessarily because of the restrictions. And through the interviews that we're doing now, we're actually learning that the fear of COVID, even though not present in WA for so long, has really impacted them, you know, way before this, you know, escalation in cases that we're seeing now. So I think overall, in terms of the impact, you know, there are certain areas that obviously have impacted slightly different, but the differences is not anything of, you know, more than say a 5-10% difference in proportions and numbers.
I was interested also in your data on the telehealth. I mean, telehealth has been promoted certainly by our hospital hierarchy and by the federal government, and, you know, with the introduction of new Medicare numbers and so forth. My experience, I think, reflects what your data showed. The vast bulk of people either can't get the link to work, or if they get it to work, it's so choppy that you end up phoning them anyway. and it's been pretty much hopeless. And I know that the item number for telephone calls, in fact, is due to expire in June. It did expire back in December, but then they had to reintroduce it. So I did wonder, and I noticed Nicole's got her hand up, with the other clinicians around, what's been the general experience? Because I think mine's not been terribly satisfactory for most patients.
Yeah. And you're referring to video?
Yeah, the video the phone works,
reasonably
well enough for people that and if it's a relatively simple follow-up, and I obviously do it not just for ILD, but for a bunch of other stuff. But the video aspect of it, I think, has been very difficult, which seems to be reflected in your data too.
Yes.
Nicole, you got a comment, question? If you've got Nicole, you're still on mute. I think you've got your hand up, but I'm not sure if you're trying to ask anything.
Yeah, I'm trying to unmute myself. Sorry.
There you go.
Just in relation to your comment, Paul, I agree. I think telehealth is actually quite difficult for this group of patients because they're all kind of in the elderly spectrum, and so they don't have the technology or the knowledge to use it. And I think we offer most of them telehealth by video, but the vast majority would opt for a phone consultation.
Yeah.
And I think that's going to be a challenge when the Medicare withdraws their funding for phone consultation in June. But just going back to Gabrielle, well, thank you, Gabrielle, for the very insightful results and presentation. But this might be an unfair question because vaccines were generally not available in 2020. But did you come across anybody who were reluctant to have vaccinations or were concerned about vaccinations worsening their health?
So this wouldn't have been covered in the questionnaire, but from the interviews, and there's been, about 90 odd interviews across with everyone across the 4 sites. I would say there would probably be maybe, 2 or 3 that initially were concerned about vaccination because they went, and mainly they were the ones that had connective tissue disease because they weren't sure whether it was going to be effective. But by and large, everyone was all for it, went out there without, sort of any hesitation at all.
Mm-hmm. And again, I'm not sure if the timing was right, but the use of masks, which sort of came in gradually over the last 2 years, I don't know if you had questions about mask wearing in your study, but
no, but through the interviews, and a lot of the health professionals that they did talk to, they all recommended masks. So I think it was just a given that mask was, anywhere they went, they would always be wearing masks as a protective measure. So,
I guess I was wondering, given that their underlying sort of shortness of breath, whether they found the use of masks particularly troublesome.
Yeah, well, some of them did indicate that, but it was the case that, if they were going out and they had to wear masks, they would wear them. If it was causing concern, then they wouldn't go out. They just stayed home. So it was a challenge for some of them, particularly the ones with, sort of greater respiratory sort of issues. But, they wouldn't have, the indication was that they wouldn't have left home without a mask.
Mm-hmm. Nicole, you got another question?
Yeah, I was just going to say, I must say, I've had a few people ask for mask exemptions, which I found really quite surprising. So I think, people generally would avoid going out because of the mask, and then they would actually ask for mask exemptions as well. So,
okay.
Yeah, so I thought that was interesting.
Yeah. I haven't sort of heard of any of the patients that I've interviewed sort of asking about that.
Mm. And I think I had written down here, did anyone actually get COVID? But I think the answer was no.
Well, not from the ones that I've interviewed or responded to the questionnaire. So.
Right, I guess that was lucky.
Yes.
Kate, I think you've got your hand up.
Yes, thank you, Paul. Gabriella, I wondered if any of the patients really liked you might have said this and I wasn't paying attention, so if so, I'm sorry. Whether they really liked the opportunity to have telehealth and would like to keep going, not having to hang around in waiting rooms and do the parking at the hospital and all that stuff.
Yeah. No, that's a good point. And in fact, again, through the interviews, we're getting a whole a lot of different groups and perspectives, and there's certainly a group that felt that, yep, doing it on the phone, I don't need to travel, I don't need to go in, I don't need to put myself at risk. Appointments are usually on time, so if someone calls me at a given time. So I think there's a whole range of perspectives, and people who would like continuing telehealth only, or those that feel it's absolutely not good for them at all. So it's going to be, I think, quite challenging, and I think it's going to have to be very much a sort of an individual thing. But even those that do like telehealth feel that at least having one face-to-face consultation, perhaps every 6 months, would be ideal.
Thank you. Yeah.
I guess by and large, the results, at least for that period during 2020, are relatively reassuring in that, most people, it seems, were relatively satisfied with the healthcare that they were getting. And I sort of alluded to it before. I mean, the landscape is constantly changing, and now we're moving to this sort of living with COVID, and it's kind of everywhere. I guess what are the main lessons that you think we can draw from your study in terms of designing services moving forward into this living with COVID phase?
Well, I think one of the key points that is constantly being reiterated is having, patients need to be have some sort of reassurance. And I think the lung function test is what really provides them with that. So being able to, particularly the ones that, are feeling like their symptoms are deteriorating, or suddenly there's an increased shortness of breath, having the opportunity to be able to bring them into, to have a lung function or some other assessment done. And I think just the ongoing, which I think the respondents have shown, the availability of health professionals when patients feel that they really need to talk to someone, or they feel that something's, changed quite significantly. So whether there's like an online or a health, a support line or something for people with lung conditions, that was something that was suggested by one of the patients, but somewhere that they can get information, talk to someone about what they're feeling, and perhaps be then referred to actually see someone to assess them.
We found with our cystic fibrosis patients, who are obviously a younger and obviously somewhat more tech savvy group, that home spirometry seemed to have a reasonably useful impact on that. But my guess would be that in this population, it probably would be a bit unsuccessful. And I think it was Toby Maher tried to do a clinical trial looking at home spirometry as an outcome, and it sort of was a dismal failure. So I don't know that would work, unfortunately. Yes. So I think, actually getting people in is critical. And in our hospital at the moment, I don't know where this has come from. They've tried to encourage us to stick to 80% telehealth across the board for all our patients, which the medical fraternity is putting, giving a lot of pushback at the moment. I mean, I think it might be all right for 2 or 3 months, if there's a real crisis, but now the longer it drags on, the more the adverse consequences of not picking things up are. And we are certainly, as a medical group, having to push back a bit against the administration on that. I don't know if Nicole's still there, but I don't know, Nicole, in your institution, are you being faced with these sort of not mandated perhaps, but strongly encouraged telehealth levels ongoing?
Yeah, I mean, as you know, we've been doing it for almost 3 years, 2.5 years now, far longer than any other state. And I must say, during the first wave, where it was literally just a blip, the mandate was, literally no face-to-face, everything was telehealth. But as we are moving towards living with COVID, they really haven't given us a lot of guidance. It's very much, clinician-led, clinical indication. So they've left, I mean, clinically in my private rooms, everyone's face-to-face now, and people want to come back. Whereas in the public service, so they've said, look, there was no mandate about proportions of telehealth. And I must say, people that are having lung function now come back for face-to-face. Otherwise, they have a choice of telehealth. So I think as we're moving towards living with COVID, I think there is no clear guidance, because I think it's really up to the service, the clinician, the patient as well. But I think moving forward, there'll be a hybrid model. I hope there will be, because I think, I think the, inequality of access in remote health would be addressed by telehealth in some way or form. But clearly we need to have a good model working forward. And in fact, delivering, blood tests, or reviewing CAT scan results often can be delivered on the phone. But I think all new patients should be seen face to face at the very least.
Yeah.
And then I think they should be seen at least once a year face to face.
Yeah. Yeah, we're certainly trying to see all new patients face to face. And despite what the administrators are asking of us, we are using our clinical judgment. Anne, you've got a comment or question?
I just wanted to say that I think it's very variable, because across the other side of the river in Melbourne at the Alfred, our experience would be much more similar to yours, Paul, in that we are being discouraged still from bringing patients in for face-to-face, and it's been much more conservative at the Alfred than it has been at the Austin. So, I think there's a way to go. We've certainly got some inequities in care at the moment, depending on where you live. So there doesn't seem to be a universal approach, really.
Okay. Any questions, comments from anybody else? All right. Well, we might we can finish a few minutes early. That's fine. Thanks very much, Gabriella. Did you have any other closing comments you'd like to share with us?
No, I think it has been a very insightful experience and learning about, how this pandemic is impacting on patients, but also I think reassuring for clinicians that you are doing a great job, and that the patients really do appreciate, the time and being available for them. And also, I think, understand, at least this group of patients, that, everyone's under a lot of pressure and that you're doing the best that you can do. So I think that's sort of my parting comments.
All right. Well, on that sort of positive note, thank you for that. We'll leave it at that. Thanks to all those attended. Look out for the notice for next month's meeting, and we'll keep this going throughout the year. And of course, I think we'll have the Thoracic Society meeting in between, won't we? So I'll probably see a few of you online or somehow or other, unfortunately, for that. It's a pity it's not face to face, but that's the world we live in. All right. See you next time.
All right. Thank you.
Bye.
Bye.